Hello, everyone. Thanks for joining us this morning. And I'm here with Todd Ball, physical therapist. I've worked with Todd now for a number of years. He's worked with our clinic for even longer. And Todd has really taken an interest in craniocervical instability rehab. And this is a very difficult patient population for most physical therapists. Most CCI patients go to physical therapy, they get flared up, they don't go back. And so Todd has really learned through the school of hard knocks, if you will, through the last several years of how to tailor physical therapy in a postural specific program to our CCI patient population. So welcome, Todd, and thanks for joining me this morning.
Thanks for having me, Dr.
So Todd, tell everyone a little bit about what you do for CCI Rehab. How does that work?
Sure. So we have an online program. We've developed a series of video library for neutral spine conditioning, and we've now tailored it and added 6 more sub-levels to be really ideal for the CCI population. So it doesn't matter where you come in at, if you're bed bound or if you're somewhat functional or highly functional. We're going to do one main thing. We're going to turn you from this person or some variation of this, someone who's collapsing their upper back and their head's not on top of the rib cage, to this individual. It takes about 6 or 8 weeks, sometimes 12 weeks, kind of depends on where you're at with the procedures and whether we catch you before a procedure or after a procedure. But we're going to condition you, our program will condition you with a combination of the video library and online coaching to function with your upper back stacked and your skull right on top of your rib cage.
Gotcha. And let's talk a little bit about that first thing that you mentioned, and that is trying to meet CCI patients where they live functionally. What's been your experience there? Because that's, I think, one of the hardest things for a physical therapist to do with this patient population, right? You've got everything from bed bound to people that can still work out and live within a functional box. So talk a little bit about that and how you morph your program based on that functional level.
Sure. So if you come in and you're not spending much time against gravity, that's a total different monster than somebody who's up against gravity and has forward head collapse posture. They at least have a dynamic and stronger musculoskeletal system to work with. If you're not functioning against gravity, your program has to start at a very basic level. That's why you see me here with a foam roller and some support to help me sit upright. I don't need to do that. I'm strong enough to hold good posture all day. But these are the things we come in at. We'll ask you to probably buy a chair to get you upright, and we can create an environment for you to stay stacked if you're coming in at a bed bound level. And I was very intimidated by those referrals at first. I did my best, but I had no resources. I had no tools to follow and nothing to give the patient from a video library perspective. But as I started taking on more of those challenges, I created these on-ramps, and now I'm very comfortable with taking somebody who's coming into the program with more time resting in a collapsed supported posture than anti-grav.
Gotcha. And yeah, talk a little bit. You've got that foam roller there. I've obviously seen a lot of foam rollers. That's sort of one of those half foam rollers. But what are the two things above and below there? So talk about that foam roller a little bit.
So this is a 6 by 36 inch foam roller. It is a necessity to start the program for many reasons. One of them is it puts your shoulders in the neutral scapular plane. So it's what we use as a resistance for overhead lifting. We're going to teach you how to do a 2-part lifting strategy. And everything's done in this neutral scapular plane. If you look at the shoulder joint, it sits off at about a 42-degree angle. And so doing and working within that plane makes it so that you can start to learn how to do functional lifting and stress the neck as least as possible. The Pro Roller Arc is another essential component. This allows us to put you on the floor, and we can position this at the apex of your occiput and create a little bit of a counter force so that you can, when laying on the floor, be in OA neutral. It requires a whole coaching session for us to figure that out and teach you how to hold that. But that has always been one of the biggest drawbacks to any CCI program is how do you start neck strengthening? You don't do it against gravity. There's just too many moving parts. The head hasn't been spending time on top of the rib cage, so you have all these long lever arm muscles that turn the head that cross multiple segments. You can't win that battle. What you can do is put them in an environment, put them in OA neutral, do core work for 4 to 6 weeks, and take away layers of progression and counter forces so that they can start to strengthen their neck, get those muscles woken. These muscles cannot be fired if your upper back is collapsed and your skull is sitting forward. They can't pull the skull back against that much resistance. So you got to create an environment for those muscles to be able to activate. And we've figured out how to do that with a lot of props. The most important is the Pro Roller Arch, and the foam roller has many functionalities within the program.
Gotcha. And let's talk a little bit about when starting rehab pre, post the PICL procedure makes sense, because you've had a lot of experience in treating a lot of our patients who have had a PICL procedure. So, should they start before? If they can't start before, how soon after? Let's get into that a little bit.
Yeah, so what I've learned working with you, Dr. Centeno, and Dr. Schultz, and Dr. Pitts, is what data do I collect to make good decisions along the way? This could be one of many pickles we don't know yet. This could be the second or third pickle that is just now ready for that functional strengthening program to develop. So to answer your question, I got to collect some consistent data from which I can make good decisions on. The most important is, can the patient learn how to move and stack T2, T3, T4? And it almost doesn't matter where they're on in the spectrum of the treatment of their CCI. If we can teach them how to stack the upper back, get T2, T3, and T4 to extend and pull the head back on top of them, we build from there. So some clients are coming in and I'm now learning this person's probably going to need more than one pickle procedure. So what do I want to accomplish before the first? Well, I want this person to spend at least 30, 40, 50% of their day upright against gravity. That's a great milestone for a person that's bedbound, so that they can at least have the procedure and start to work dynamically their musculoskeletal system in a healthy way. If they're pretty active, then I have to mostly pull them back on stuff they think they're going to do post-pickle that they shouldn't do. And what they tell Dr. Centeno is not what they tell me. And so, you got people who had a pickle 2 weeks ago and they're playing pickleball. And so, it's about, hey, this is what you should be able to demonstrate before you do that. And it's creating the appropriate bridges for them to meet their goals, but do it and preserve the integrity of the procedure.
Okay, so let's get into prehab. So if we focus on prehab, which is rehab prior to a PICL, about how long would you want to start, ideally, before your procedure?
6 weeks is ideal because it takes 2 or 3 weeks for them to learn how to stack their upper back, and the musculoskeletal system is going to respond to that. Not have a flare up, although they perceive it to be a flare up. It's just they're asking a muscle that's really tight and hanging on for dear life because the head's tilted the opposite way to now relax. And it's going to have to be coached to do that, and has to be asked to do that within a realm of time that allows it to feel comfortable to do that. So there's about 2 or 3 weeks where they start to not have as much of a reaction, stacking themselves, and then we teach them how to do basic movement patterns for another 2 or 3 weeks. You add all that up, 6 weeks is ideal, Dr. Centeno, for taking them, teaching them how to get into neutral spine, teach them how to do basic activities they're going to have to do after the procedure without forward head posture.
Great. So 6 weeks before sounds about right. And then let's go after. So after a PICL procedure, obviously the response, as you just pointed out, is pretty variable, right? You've got everybody from major league flare up to, I don't know that they did all that much. It's a little bit sore maybe, but I'm able to do everything I need to. So where do you enter in then afterwards in those two extremes?
Well, I follow your guidelines in that table you've made for what you expect to be the anti-inflammatory response, and then that calms down, and then we want to come in and try and catch them at that 3 to 4 week mark and get them back to just showing and demonstrating. If they came into the program pre-pickle, I don't have to teach them how to get into neutral. They're not going to lose that access post-pickle and post-procedure. So we can go right into the level 1 pickle workout at week 3 and 4. But I'm learning and gaining a lot of experience on, hey, this person, we're just going to stay at seated mobility stuff because I think that bell-shaped curve lasted a week or two longer. So some of it, it's all individualized based on what I see online. I can see a lot of things online you couldn't imagine because I'm running them through a very structured program. So I'm not asking to do 8 different exercises every time. I'm asking always do the same exercise. If they show the 4 principles being applied, I'm confident their musculoskeletal system is ready for the next challenge. So it's the difference between PT and an exercise system. And an exercise system can be a lot safer as long as it's the right exercise system for you because they're not making decisions and trying to adapt the program along the way. They're just scaling back what they expect from you within a structured system.
Okay, so let's go with the patient who's in a major flare-up. So let's say PICL patient, 2 weeks out, still pretty flared up, still increased symptoms. Where would you start at that second week? Would you say, let's give you some time to calm down first? Where would you enter in at that point?
So if they're communicating with me and they can't pre-pickle, I'm talking to them totally different. I would say, let's wait till week 3. Let's let this calm down, but use your props. By that time, they know how to put a foam roller underneath their elbows to take the weight of their arms off when they relax. They know how not to relax and slump posture. So I'm saying just stay with what you know that you can tolerate that doesn't seem to flare, because the flare has to calm down. I mean, there's no reason for me to try and take you and build something special from you if your body's telling you it's being overwhelmed. So you got to let that come. Now, that doesn't mean you don't do anything. If I saw you prehab, we can talk a language and have you do some stuff, but it's not anything consistent with a whole level 1 workout, as benign as that workout is. It's some modified version of that. But if I've never worked with you before, I'm going to be super conservative. Your body doesn't know how to get in neutral. I need that process. So that's a patient I might say, let's wait till this thing flares up, and I might even leave the physician on that because they know the medical history a lot more than I do, and they'll tell me, Todd, I think this person. So it's my confidence level is based on how much time I work with you pre-pickle.
So again, yeah, a lot really depends on that prehab or pre-pickle relationship to try to see who this person is, how they're responding, what they know already, what they can probably do without causing a flare. So let's get into some specific questions. Allie, I can't seem to correct my posture because I get dizzy when I do. My posture is bad and I have a straight neck. Any comments on that, Todd?
Yeah, so there's just a lot of misconceptions of what a good posture is. A lot of people still think it's retracting your shoulder. It is absolutely not that. Uh, and everyone's 80% of everyone needs the same thing. They need to stack their upper back more. So that's a general truism. Now, what you should do to stack your back is individualized to you. That's why not my videos are online. I don't know when you're ready to learn how to stack your back. You're probably ready today, but I don't know if you're doing what you should do the right way until I see you. And so learning how to stack your upper back to pull your head on top of you is something you should be able to start doing today on some level. That some level requires a skilled practitioner, but it does not consist of something aggressive. It does not consist of retracting your shoulder blades. It consists of some mobility exercise to get these vertebrae and all the ribs that attach to them to feel comfortable to allow a movement that the nervous system above and the musculoskeletal system around does not want any part of. So you're going to try and do something someone tells you that's healthy, but your musculoskeletal system is going to fight you, so you're probably not going to do it right. And that's probably why you're butting heads. And the dizziness comes from forward head posture throws off the vestibular system, and it starts to dominate the environment. So you got to work around that. You got to understand is what I'm asking her to do. Is she doing it right? Is it appropriate for her? And then let's have her do it long enough for the vestibular system to calm down and stop fighting her. Very complicated. None of this stuff's simple, but it can all be managed with very little bit of online coaching and the right system.
So Allie, so one of the things I would say, Allie, is obviously getting with a physical therapist who understands this patient population. Todd's a great example. At the same time, it's certainly possible, in addition, that you've got an upper cervical issue that would have to be taken care of through treating that upper cervical issue before you could do that type of rehab. So that could be upper cervical chiropractic, Duca AO, that could be specific injections in that area. But it also could just be changing the rehab approach from the ground up. Is it better to start PT after the PICL? So I think we've answered.
Yeah, the second that Dr. Centeno, one thing I've learned was that the science of your procedures, it's blown me away. I used to be the gunslinger that thought I could fix anything. And then you learn, okay, there is a ligament and stability here that's outside of my scope. And so the pairing with the science of your procedures, I'm blown away at how much we can help this population. The combination of two and the right new practitioner or chiropractor who knows how to put that segment in with the least amount of force.
Yeah, for sure. So in this one, we've answered this, but probably good to answer once again. Is it better to start PT after the PICL procedure? The best thing to do is to start prehab before the PICL procedure. And then if you had to start it afterwards, then when you start it, it's going to really depend on your response to the PICL. So it's that thread the needle that's in the rehab program. Thread the needle means that, let's say you're really, really sore or flared up for 2 weeks, then you're going to wait until that flare up sort of comes back to your normal state before you're really starting to rehab. Now, for some people, that could be 3 days. For some people, it's 2 weeks. For a few people out there, it's 2 months. But if you have a pre-existing relationship with someone like Todd and you're doing prehab, then that makes a big difference, right? Because that provider can say, I know this patient, I know what they can easily tolerate or not. Here's one for Todd. My work as an artist has me hunched over a lot. Is it possible to help train for a good posture in that form to keep doing my type of work? So that's an interesting one, Todd. The concept here is that maybe some bad posture is necessary to do the work. Is that your experience, or can you reorganize this to get good posture while you do your work?
It depends. If he's doing pottery, yes, we can teach him how to put. And I don't know what work or medium you're working within, but a good example is a guitar. Most guitarists think, I can't play a guitar. I gotta be kind of collapsed and rotated. But you don't have to be this person. You can play guitar in here. You have to use what we call a hip hinge. And so how do you change the position of your head through your lower body? And so the pelvis has, and then how it articulates with the hip, has a lot of room for tapping into changing the orientation of your spine without any neck flexion. So I need to know a little more information, but there's absolutely a potential for you to learn how to do your artwork and your job with less collapsed posture. We can definitely take away some rotational components, most likely. But we might say, okay, this is as healthy as you can do that activity, but that activity is only 13, 15% of your day. Let's get better in these other areas so that when you do that activity, it's more awkward to the nervous system, and then the consequences of it and how the body remodels around it are a lot less impactful. That's how I would handle that.
Gotcha. Todd, what is your opinion on compression biofeedback equipment for gentle strengthening? So something like BFR. Have you used BFR? I would assume it's pretty hard to do BFR on a neck. So that may not be practical for most of this, but let's say BFR or blood flow restriction for other aspects of one of these programs. What are your thoughts on that? And first, telling everyone what this is, because they may not know what BFR is at all.
I honestly don't have an intelligent opinion on it. I don't have experience on it. It's just not my wheelhouse.
Gotcha.
I'm a
So I'll
physical
take this one. So blood flow restriction is basically using a blood pressure cuff. Usually it's done with a upper or lower extremity strengthening program. And what's unique about it is if you put this little device on, and let's say you try some biceps curls, and let's say you normally do 30 pounds for a biceps curl to work out, 30 pounds is going to feel like 300 pounds. So you could do 5 pounds and it'll feel like 50 pounds. So BFR is just a way to reduce the load on the area, but to still strengthen the muscle. At least that's the concept. Now, BFR for the neck would be very hard to do, right? Because there's lots of important things in here you can't cut off by putting a blood pressure cuff around your neck. So it's not going to really work for cervical rehab. It would work for upper extremity rehab, for lower extremity rehab, that kind of stuff. Let's see here. Another one for Todd is good posture about keeping your chin slightly raised and always looking towards the horizon. Should we try to do that even before the PICL?
So I don't know that I agree with the first statement. Is good posture keeping your chin slightly raised. We teach good posture. Well, we teach neutral spinal alignment, and so one thing that's a truth across the board, no matter how many people want to discuss the many ways of describing healthy neck curvature. Your upper back, if it's collapsed and your skull's anteriorly displaced like this guy, we have the ability, every one of us, to learn how to stack T2, T3, and T4 and put the skull on top. And that is what my program does. Now, within that, what happens after 6 or 8 weeks of you functioning 50% of your day from here, there's remodeling is going to take place. And that might be 6, 8, 10, 12 weeks. However long it takes you to start spending 51% of your day stacked, there's remodeling that takes place, musculoskeletally, structurally, all positive things. I don't really get all that caught up into this neck curvature. There's people out there that really know a lot about this. I've learned a lot from Dr. Katz through the years. It's not what we do. We condition you to put your skull on top of you, and we think that is what should be taught across the board as a first step. Because a lot of the other things we're doing that are reactive to symptom overload or mechanical overload may not be necessary if you just condition the patient to function with the skull on top of them. Get some dynamic stability in these muscles, get them to be active, retrain them how to do their job, and then everything else will have a much better outcome, whether it be a pickle procedure or any other treatment, to try and get the cervical spine to function in a way that's optimal. We actually don't have any neck stretches or exercises in the program. Everything's done from pelvis, ribcage, and skull being in a neutral relationship with each other. And whatever happens along the way, it's going to happen. We're going to teach you how to not collapse, remodel how to do movement patterns from a stacked upper back, and only good things happen as a result of that.
So just to summarize, I think to answer this question more specifically, that is, the question is, should I walk around doing this? And the answer is, should really focus on more getting your head over your shoulders over your lumbar spine, etc. So just sort of changing that nodding C0, C1 motion might help a little bit, but it's got to be that total body posture that Todd's talking about. So specific question about, does this type of rehab program work with a hypermobile EDS patient?
So again, not to be redundant, but if you have hypermobility and you have one part of your skeletal chain displaced anteriorly your skull, it's going to magnify and make joints that are already unstable do more work than they can tolerate. So let's simplify things. Let's get the skull on top of you. Let's wake up the muscles on the opposite side of the joint of your most unstable segments and build a movement pattern around that. And only good things are going to happen. And so going back to the previous question, We actually don't cue what to do with the skull on C1. We teach you to stack your upper back, and most people in a forward head posture, when they stack their upper back, are looking up, and we're like, well, just nod your head so you're looking straight ahead. That's as much as we cue what happens at C1. But that's usually enough, because you're already overwhelmed with just the stacking of the upper back. Now, when we get into the fitness phase, if you got some stuff going on in the cervical spine, we're addressing that. But during this phase where you're just out of control and the nervous system's overwhelmed, and we want to get some sort of musculoskeletal control in the area, we keep it super simple. But as you go through the program and get to higher levels of function, we're going to start talking about maybe consider curve correction. I think those are part of the limiting factors and what you need to go to the next level. But we rarely, very rarely encounter those things, because you now have 3-4 months of functioning without your head being transferred and positioned anteriorly, and your musculoskeletal system's remodeled around.
So, so everyone, we have Todd Ball here today. Todd's been working with the clinic for many years, helping us with CCI Rehab. What we really like about Todd's program is it's online. That allows us to apply it to all of our different patients from all over the country. The other thing we really love about Todd is that Todd has really gone through the School of Hard Knocks to work with a very difficult patient population and understand how to morph what it is he does as a physical therapist to meet the functional demands of each patient, which can be anything from bed bound to I'm still lifting some weights. So that's really fantastic, right? Because a lot of physical therapy in CCI crashes and burns. The patients crash and burn, and they never want to go back and see another physical therapist again. And it's not because PT isn't needed in that person. It's just because they got a one-size-fits-all approach. So I want to thank Todd for being with us here today, because he's not a one-size-fits-all approach. And I think he's done some really fantastic things for the CCI community. Todd, any last words for us before I have you drop off and get to all these mounting questions I see here?
Sure, sure. Well, thanks for having me again, Dr. Centeno. It's always a pleasure. Two things. One, I encourage you to go to posturetv.com. That is an AI-driven platform, a dashboard we're developing, where you can give us a motion capture. You're not sure you're doing something properly, take a 5-second video of yourself, send it to us. Also, it can work in the background and tell you when you start to slump out of what would be your optimal posture. So that's free for now, as we're just doing beta testing and developing that dashboard. Number two, if you're going to consider physical therapy, if your physical therapist wants to strengthen you from a collapsed posture, that is probably not the right approach if you have neural symptoms that are associated with upper cervical or even just neck pain. The skull is 8 pounds, and every little centimeter it sits out in front of the upper thoracic spine, it weighs more and more and more. And so to figure out and find someone that can help get that skull on top of you, and then traditional methods for strengthening the neck can possibly be appropriate. That would be my go away advice for people looking for a physical therapy solution. Physical therapist will be able to guide you in the right direction, but if their on ramp is too aggressive and they don't address the posture first, look into some other options.
Yeah, I think that's a great way to put it. The on-ramp is too aggressive, and oftentimes in CCI patients, the on-ramp is too aggressive, and that's what really drives this whole aversion to physical therapy. Well, thank you so much for being with us, Todd. I'm going to get to these other questions, and I'm sure I'll be talking to you this week. Thank you.
Thanks, Dr. Centeno. Thanks for everything you do.
Thanks. Okay, so let's see here. Let's start getting to some questions. Is it normal to still have pain in the aspiration area on the right side a week after the procedure, particularly when the pain feels sciatic in nature? I had pre-existing sciatic injury years ago. It can be. Certainly, it's possible to still have soreness in that area, but that's something you may want to, it sounds like you're talking about a bummer aspiration site. So that's something you probably want to bring up with that physician, so that that physician can take a look at that and make sure that that's within the realm of what it is should be happening. Let's see, is Regenexx the only system that can get 10x platelet concentration? No, you can get higher platelet concentrations with some systems that are out there. The problem is that it's hard to do and it's kind of off-label. What I mean by off-label is the system really wasn't designed to do that from the outset. And so you've got to sort of play with the system in order to try to get higher platelet concentrations. Regenexx is one of the only ones that's actually designed from the ground up to get up to 20x concentration. And so obviously that's a different animal, right? If you've got a system that's designed from the ground up to do that, it's going to be more reliable in getting that done. Good morning. On report, I show 2B, 3.1 left, 2A, 3.1 flexion, 1A, 126, curious about significance of causing symptoms. So if you're talking about 3.1 millimeters of overhang, that's on the cusp between normal and abnormal. So that may or may not represent a type 2B CCI. 3.1 millimeters in ADI inflection depends on where that comes from. If it comes from an MRI report, that's going to be less accurate. I'd probably want to make sure we measure 3 different areas: the top of the ADI, the middle of the ADI, the bottom of the ADI. So that could be abnormal, that could be normal, depending. 1A or a CXA of 126. 126 could be normal inflection on an upright MRI, but a lot would depend on what else is there. So hard questions to answer without more info. Let's see here. What do I tell my PT provider that spends almost all their time on dry needling and little on other manual techniques? That's a good question. I think trigger point dry needling can be very helpful in this type of problem, but you also have to do the postural work, the strengthening work, etc. So if they're not doing that postural work and the strengthening work because all they want to do is dry needle, then probably find another physical therapist. Let's see. Good morning, Dr. Center. Familiar with Northwest Center for Rehab Med, Dr. Jamie Lewis, Washington State. I believe Jamie is a Regenexx provider. For Regenexx providers, their focus is not going to be on CCI. So we don't recommend any Regenexx site for treating craniocervical instability outside of Colorado. But obviously for other things, many are going to be quite capable in treating quite a few other issues elsewhere in the neck, lumbar spine, shoulder, back, hip, etc. And before the PICL, should we still try to move our neck or should we avoid it? You should always try to move as much as you're able to move. One of the things that I just posted a video about this morning was that I see a lot of patients that are hypokinetic, meaning they're afraid to move and they've been told not to move by various providers. So they come in with 2 problems, right? One problem is they've got CCI. The second problem is they've lost most of their neck range of motion. Those patients are going to be harder to treat than the patient that maintained their neck range of motion throughout. So just realize that if you are afraid to move and you're not moving, then that's not a net positive, that's a net negative. What week would you recommend starting? I think we answered that one there. My L5 spinal herniated disc issue and OE, and also the spine became straight. It corrected my physiotherapy. One day I started getting tingling everywhere. Not quite sure with the question there. Do you have a pillow to recommend that helps achieve a good neck curvature? Pillows are very, very specific to the person. In general, I think a good advice is to try to get your head in line with your neck. And if you've got a pillow that can maintain that relationship in all positions, because some people are side sleepers, some people sleep on their back, then I think that's going to be a better pillow for most people. So it's really more about maintaining that neutral position between the head and the neck and the shoulders. and keeping that in a straight position. And that means that different people, based on their size, their body habitus, are going to need different pillows. What do you think about curve correction using weights crisscross to pull the mid-neck forward? I don't think that's a good idea. I've seen too many of my CCI patients flare with a curve correction neck program. So that's a big concern. And, listen, it might work in some patients, but I've just noticed a lot of CCI patients getting flared up by using neck weights. So I don't recommend my CCI patients to use neck weights for that reason. Let's see here. Hello, Dr. Centeno. Thank you, Vance, for your precious time. You're welcome. Is there any chance that CCI may make a difference with prolotherapy improvement for neurologic symptoms? Dominique, at CCI, it's all right. Let me start over. Dominique, at Centeno Schultz Clinic, it's all about getting to a specific diagnosis of CCI. So, for instance, if you had a type 3A CCI, then prolotherapy posteriorly might be a really good thing to try. If you've got a type 2B CCI, where C1 is sliding sideways or rotating too far on C2, not so much. We're not going to be in a situation there where prolotherapy posteriorly is going to be very effective. So it really depends on the diagnosis and that specific diagnosis. Mike, it's believed I have fluoroquinolone toxicity and a bad CCI injury from a fall. Can you comment about the correlation between the two and what complications could occur while being on these antibiotics? Mike, we don't have much information that shows that fluoroquinolones do much to ligaments. There is some information that fluoroquinolones can hurt tendons, but we really don't know much about ligaments. I do these searches periodically. There's really no new data here. So at the end of the day, my sense is one may not have anything to do with the other. Now, having said that, if someone had a fluoroquinolone toxicity and lots of tendon problems, that's obviously going to change lots of things about how the musculoskeletal system works. So maybe that put that person at a higher risk of developing more severe issues if they were to get craniocervical instability or an upper neck injury. Let's see here. Vero, hello. I often have a sharp burning pain in the suboccipital corners at the CCJ, and it often turns into a headache. It worsens with rotation, like sleeping on my side. What could this mean? My DMX overhang was normal. How can I tell if the pain is coming from the muscles or the joint? Yeah, Vero. So first thing to realize is there's CCI and then CCS, right? So CCI is craniocervical instability. CCS is craniocervical syndrome. So those are two different things. They both involve symptoms generating from the upper cervical spine. And those symptoms are things like headaches, dizziness, imbalance, spasm in that area, etc. Now, for craniocervical syndrome, that could be due to an injured joint or an arthritic joint in the upper neck. That could be due to problems with those upper neck muscles like the suboccipitals you're talking about. And if the pain is kind of coming from the corners of the suboccipitals, that could be the greater or lesser occipital nerves getting irritated. So there's a bunch of different layers of the onion that have to be peeled back there to see what's causing what. It's usually not as simple as just occipital neuralgia. The thing that needs to be asked is what's causing that occipital neuralgia. That's a key component. JS, I had a craniosacral treatment 2 weeks ago. It helped my dizziness, brain fog, energy, and neck pain. Do you explain what that treatment did for my symptoms? JS, I'm not sure I can. Certainly putting any pressure in the suboccipital area can reduce spasm of those suboccipitals. That's important because those have position sensors, and those position and muscle length sensors are tied directly into the balance system. So at the end of the day, realize that if you were just to do some suboccipital massage in the right way, you might be able to reset some of that and help someone's dizziness. Hutchinson, my daughter has had one PICL, AO treatments flared her both prior to the PICL and after. Should she keep pushing? No. We only recommend that someone continue with AO or NUCA if they had a good result before the PICL. We don't recommend that you just continue to really with any or to continue to use any treatment that causes a flare-up. That would include AO or NUCA. So at the end of the day, if AO or NUCA didn't work before and they're not working now, time to move on from AO or NUCA. Mike, can you comment on the correlation between CCI and orthostatic hypotension? Well, CCI can cause irritation of the vagus nerve, which can cause all sorts of problems with lots of different systems, including the heart and including how the blood vessels react. Now, there are other nerves in that same area, the sympathetic nerves, etc., that can also have that effect. So that's how they're usually tied together. But you also need to make sure that the orthostatic hypotension is fully worked up, meaning you can't just rely on claiming that it's CCI that's causing that issue if you've not had a workup from a competent specialist to say there is nothing else that seems to be causing that orthostatic hypotension. It's been advanced by Sherry Scott. Where is Todd located? Does he work with people online? Yes, Todd works with probably 90% of his patients online. Let's see here. I think we got some of these. Is a standing motion MRI as good as DMX? They just show different things. So a flexion extension upright MRI, for example, is good at diagnosing, let's say, type 1A and type 1C CCI. It's not so good at diagnosing type 2A. It can't diagnose type 2B. And it's not so good at diagnosing types 3A and 3B, but it can. Whereas a DMX is very good at diagnosing types 2A and 2B, not so good at diagnosing 1A and 1C, and much better at diagnosing 3A and 3B. So as you can see, you've got different things that each imaging type is good at, and you can't really look at one in isolation. Now, we can get to, are you a PICL candidate, many times by looking at one or the other, but they find different things. Mike, how do you share information between each other with the care of your patients? I think what you mean is, do I share information, for instance, with Dr. Schultz and Dr. Pitts and vice versa? We do that all the time. Ali, gotcha. Vera, other than keeping good posture, what can we do to care for our neck long-term and slow down degeneration? Yeah, Vera, the biggest things are, obviously, if you've got good posture, you've corrected your curve, that's another big one for slowing down degeneration. Then eating right, staying healthy, staying a normal fit weight, and staying strong are the other things that you would do. For example, if you're 30 pounds overweight, that's destroying your musculoskeletal system, not only from the standpoint of additional wear and tear, but also from the standpoint of much higher levels of systemic inflammation than someone that isn't carrying all that extra weight. Neurologist wants to do Botox injections in the head and neck for headaches, but I have pinched nerves and instability in my neck. Will Botox cause further weakness in my neck or other problems? Yeah, Botox isn't a treatment for pinched nerves and instability. It would not even conceptually work. Now, you might get a little bit of pain relief, or it might make things worse. If you've got instability, in my experience, Botox weakens the muscles, which are required for stability. So it increases the instability. So Botox is not a treatment for those things. It sounds like this particular neurologist is using what I call the hammer and nail philosophy. I have a hammer, so everything looks like a nail. Botox is not a treatment for pinched nerves. It's not a treatment for instability. Let's see here. Will sleeping flat help posture? Not sure what you mean by sleeping flat, but if what you mean is keeping your head in line with your neck, in line with your shoulders and upper back, then yes, that's generally better. Low CXA, what's the threshold for conservative treatment versus surgery? Yeah, so we start to get concerned about a low CXA that gets, let's say, lower than 125. I'm not concerned, for example, by 130, but again, all of this has to be put into context of what the structure looks like. So there are CXAs that are 126 or 125, and because of how the surrounding structures look, not as concerning. There are CXAs of 128, and because how the surrounding structures look, meaning there's more of a retroflex dens, there seems to be more contact between the dens and the upper cord or the medulla, that might be more concerning. So it's very context specific. I think that's a question for Todd there. Do we do consults longer than 30 minutes? My consults are, well, my telemed consults are generally 40 minutes. Our consult with Schultz felt rushed and left us with more questions than answers. Yeah, I don't know that I can comment on that. I can tell you my job is to try to get through as many of those questions and answers as possible. But then I supplement that with the Reddit thread so that people can go on the Reddit sub and ask additional questions. Obviously, patients email me all the time and ask questions, and I answer my questions that way. Then obviously, we've got this type of forum as well. So it is certainly possible to see a patient that has many, many more questions than you can answer reasonably in a 30 or 40-minute time frame. But again, I try to make sure that I'm available in these other ways for those patients so they can get more questions answered. During rehab, can we also work on pelvic position, which can influence the neck if there's hyperlordosis? Can specific injections help with lumbar hyperlordosis? We're not going to really be able to fix hyperlordosis with injections, but I think you bring up an important point, and that is what's happening in the lumbopelvic spine is impacting what happens in the neck and vice versa. So it's very important to understand that if you've got problems, let's say in the pelvis, that those may need to be addressed when we're addressing your neck. And that's an important component of treatment because one can impact the other. Can this approach stacking up the back cause other forms of malcompensation, such as rib flares and more vertical posture in lower segments? It's certainly possible, but usually that helps to sort of dial back the layers of the onion. And what I mean by that is at the end of the day, let's say you have someone where they've gotten their head over their upper back, and all of a sudden their lower back starts to hurt. Now we've kind of uncovered some other issues that have to be treated there. Now we can start to peel back the layers of the onion by focusing on what's going on with that low back. We can start to peel back the layers of the onion in other ways as well. Let's say the low back needs to be treated to get to the next level. It might need some injection-based treatments to get to the next rehab level. So that's a common back and forth thing that we see, that when one area is fixed, sometimes other areas light up. And then the big question becomes, what do you do with the other areas? I think that was Posture TV, but not 100% sure, but I'm pretty sure that's what it was. Mike, can you go in detail about how CCI restricting and cutting off blood flow and spinal fluid to and from the brain can potentially injure the brain? How can you confirm spinal fluid leakage in the ear? Well, we don't really have any data right now that shows that a decrease in fluid to and from the brain, really CSF flow, injures the brain. Now, there's some mounting research that is connecting some neurologic diseases to patients that have that decreased flow. But our ability to understand that is really in its infancy. So realize that we are still learning about all of that. Having said that, is it great to have decreased CSF flow because you have CCI? Probably not. And the way to treat that is usually to try to help the CCI, which can then improve that CSF flow. But it's also important to realize that we are just starting to learn about what all of that means. What does decreased CSF flow in around this frame of magnet mean? Which diseases is it connected with? Do we really know that A is connected to B? That kind of stuff. Can CCI worsen over time? Is this due to movements that can displace the cervical vertebra, or is it explained by something else? It's really, in general, when I see it happen. So the question here is, can CCI worsen? I think if you just leave it alone and don't do anything. And the answer is, in most patients, based on my experience, it does worsen over time. Why does it worsen over time? It generally worsens over time because there are structures that are causing the symptoms that are getting more beat up and worn out, hence more symptoms. Ali, how long for BMC to the joints relieve some of the neurologic symptoms? That takes longer. So for PRP into, let's say, facet joints, I think is what we're talking about. You might look at a response in 2, 3, or 4 weeks. For BMC, or bone marrow concentrate, or these stem cells taken from bone marrow, that's going to be longer, generally in the 1 to 3 month time frame. What about Eagle syndrome? I think in this context, realize that Eagle syndrome is dynamic. So Eagle syndrome, for those people that don't know, is when you get pressure on the internal jugular vein, usually by the stylohyoid ligament. In CCI patients, it happens with movement. So the goal is to get rid of the movement. The goal is not to cut the stylohyoid ligament. The goal is not to get surgery to shave down C1, because those things increase instability, and we already have an instability problem, i.e. craniocervical instability. So that surgery may still be needed after that person gets treated with injection-based care for CCI, but realize at the end of the day, that's not the first choice, because if we do that as a first choice, we will increase the instability. And the goal of the treatment is to decrease the instability, right? We want to get that instability down, not make it worse. Hey, Dr. C, continuing work with an IPA PT. We've had an aggressive tongue press to the palate component while rehabbing some occipital muscles for better control. Does that make sense to you? It does. I think that's a good way to go. My C1, C2, both very unstable. I've been going to Blair chiropractor for 6 years now. It helps a lot, but it slips out. My C1 slides forward and rotates on both sides. Can PICL help me? Again, I would need a diagnosis. So that's not a diagnosis. A diagnosis for something like PICL would be a CCI type, right? 1A, 1C, 2A, 2B, 3A, 3B. And then from that diagnosis, we can map a treatment, which might be advanced posterior injections. It might be PICL. But that description isn't a diagnosis. So we have to get to an actual CCI diagnosis and type before I can say this or that might need this or that kind of treatment. Have you ever experienced that someone who couldn't do much before can go jogging and do sports again after your treatment? So are you considered cured? Do we have patients that have returned to high-level physical activity? We do. A lot of that depends on the depth of the hole, the functional hole that's been created before we get the patient. So let's say we have a bedbound patient. Do we have many bedbound patients get back to running marathons? We don't. Those days are probably done for that person, especially if they've been in bed for a long time. Now, short-term bedbound, that's a possibility. Having said that, if the functional hole isn't severe, many of those patients return back to their normal activities, and for some of them, that would include jogging, etc. Good morning. When doing further EPICLs, do you notice changes in structures previously injected for improvement healing? We do sometimes, Julie, yes, notice changes, but realize that for what we're doing with an EPICL procedure, we're using imaging guidance to make sure we're in the exact right spot. And that doesn't always lend itself to seeing big changes in structures. Is having the tip of C1 touch the skull extension indicative of CCI? It is not. No, we don't have any data. Now, that's an interesting one. That's one that Dr. Katz and I have gone back and forth on for years. We'd both love to see if that's associated with symptoms in the same way that C1, C2 overhang is associated with symptoms. But right now, it is not an indicator for craniocervical instability. And just so that everyone knows what's being talked about here is when you go into extension, in some patients, you see the back of the skull hit the back of C1. After moving my neck in flexion, I experienced weird symptoms in my throat. And since then, a little less pain at the base of my neck, but throat problems. Is the irritated nerve no longer the same? You know, I would have to have a lot more information. Certainly what you could be describing is you kind of auto manipulated and perhaps got the relationship between the skull and the atlas and C2 a little better, but hard to say based on that description. Let's see here. Alibaba, Zumba. My C1 kept going out and discovered it was my styloids pulling out of alignment. I got them fractured last year and resolved everything. The bones fused back, now having POTS and pain again. I don't know what fractured styloids mean. Maybe I think you're saying you got a styloidectomy. That could be, or maybe a C1 shaving. Yeah, so if you have craniocervical instability, then that's not going to help. So I think you're experiencing what many patients experience who have C1 shaving or styloidectomy and have CCI, is that the symptoms just return, and oftentimes with a vengeance. Why did they return? For the same reason I was talking about before, and that is taking out those ligaments or shaving down C1 increases the instability, and craniocervical instability is an instability problem. So if we increase the instability, that's not good. Greg, apologize for the previous confusing question. I was really trying to understand type 1C numbers. Shows BAI extension 10.8. Thought this was measured translationally. It is measured translationally. So we don't generally make a type 1C diagnosis solely based on a single measurement in flexion or extension. It's made on the difference between flexion and extension, or what's called a translational BAI. Courtney, dizzy a lot. And yes, I do notice that certain head movements make it worse. But when I do laser exercise, laser on head and trace and maze, I'm not dizzy in those head movements. Does this tell you anything? Courtney, I think that's wonderful. I think what that tells me is that you may have more proprioceptive dizziness from problems with the upper cervical muscles than craniocervical instability, because most CCI patients can't tolerate that and don't have that response. So I think that's great news. So I would try to find a provider who can work with you on those suboccipital muscles. IPA physical therapy would be really good. It's IPA like the beer, IPA, Independent Physical Therapy Association, I think. But they have the kind of training that might be able to get you to the next level. Obviously, they'll have to do their own eval and see what's going on. Have I heard of hyperarch fascia training? I heard they've treated many CCI patients in the past few months. I have. I haven't had a lot of patients that have reported fantastic things with it. But, you know, I've probably heard maybe 5 or 6 patients talk about it, but that's about it. Courtney, what imaging is needed to know if something is going on in the pelvis, to know if CSC should treat it? Generally, Courtney, it's not imaging in the pelvis. It's more important to get the lumbar spine imaged, and then we can do an SI joint exam. So a lumbar MRI plus an SI joint exam is frequently more powerful than getting an MRI of the SI joints. Post-whiplash, in addition to ligament sprain, there's a palpable nodule around 5/6 where there's also a mild bulge. It is found not to be a trigger point, which I don't think it is. Would trigger point injections be possible treatment? You know, that's not something I can answer in this kind of context as a physician. I need to know more in order to know whether or not trigger point injections would be good for you. Thank you for pointing that out. Any PRP kits make platelet lysate? No PRP kits make platelet lysate at this point. We've been using platelet lysate at Centeno Schultz Clinic for 20 years now. Platelet lysate has certain advantages over leukocyte-poor PRP, and there are no kits that make it. You've got to make it in a lab. Okay, guys, there's more questions coming in, but I am getting towards my 1 hour here. I'm going to try to go and pick out some interesting questions here. Can the tendons that originate from C2 spinous process be injected with palpation guidance? I mean, they could theoretically. It's just not a good idea, right? Why would you do it that way? Either you're doing it that way, either because you didn't get the memo and haven't taken the time to train on using an ultrasound machine. Ultrasound machines are cheap and plentiful these days. So no, I don't think it's appropriate to do without at least ultrasound guidance. Okay, what else do we have here? I don't know if I'm going to tackle this one. Let's see here. Recently diagnosed with global mild CCI types 1CD, 2A, 2B, 3A, 3B. My main symptom is left-sided pain behind the SCM around C1, C2. Does PIC help with neck pain? Is the main symptom for context. A very large 5/6 herniation found a couple of years ago. Soon after I found out, I got severe spasm, debilitating neck pain left side ever since. Again, Karen, you would need to get a telemedicine evaluation in order to get typed and to see what's going on specifically with you. So I really can't comment on whether or not we can help you based on that kind of description. Doctor, you should perform these injections in Europe. Someone should handle patient registration. Yeah, not interested in performing anything in Europe at this time. I have to tell you, would not be a fan of medical care in Europe, and would not want to get into that at all. It's just it's not a medical environment, I think, that as a U.S. physician I'd be happy practicing in, because it's very, very, very different than the U.S. Okay, I think we're good there. Are proprioception injections posterior or anterior? There really aren't any. I've never heard of a proprioception injection, Courtney. So I'm not quite sure what you're referring to there. Maybe there's a different kind of injection you're referring to. Okay, guys, I want to thank you for spending time with me on this Sunday morning. I also want to thank Todd Ball for taking time out of his day to do this on a Sunday morning with us. As I've said, I've really been impressed by Todd's stick-to-itiveness in trying to understand the CCI community and the CCI patient population from the standpoint of being a physical therapist, because most CCI patients don't have good experience with physical therapy, and Todd's kind of morphed his program and remorphed it and changed it in order to make sure that there's a good fit there. Also want to thank everyone for the great questions, because questions are a fantastic way to learn. And let's see, so this next week, I should be doing this, right? It'll be the 21st or something. I should be doing this next weekend as well. And then we'll have to play it by ear through the holidays. We'll see what family responsibilities are, etc. But at least for now, I'll be back next week to answer more questions. We'll probably have either another person on to interview or another topic to discuss. So hang in there. And then also do me a favor, give me a like, share, subscribe, because that's how others find this content. And it's really important that others find this content. If you found it, you certainly would want to make sure other CCI patients can find it. Thanks so much. Have a great weekend and have a great day.